All right, everyone. I think I finally got the AV situation figured out. So thanks, everyone, for coming. And a special thanks to Kinesport for allowing me the opportunity to talk about something that is very near and dear to my heart, and that is blood flow restriction, or BFR. And I also want to give a special shout out to Dr. and researcher Yoshiaki Sato, who first devised the concept of BFR back in Japan in 1966. He called this innovative training method Katsu training, which means added pressure training. Without him, well, we wouldn't be here. I certainly wouldn't be here today. And I'm sure he could have never dreamed about how popular BFR has become and how many people it continues to help. Hi, my name is Nicholas ROLNICH, and I'm the founder of the BFR Pros, a company whose mission is to truly help people and make this world a healthier and happier place to be by getting people back to the activities that they love as quickly as possible and getting them to experience the joy of pain-free movement. I'm here today to talk to you a little bit about the science behind the power of BFR, or blood flow restriction. And it's such an exciting time for all of us, because after the 54 years since Dr. Sato first devised the concept of BFR, it's now becoming mainstream because of all the research supporting all of the amazing anecdotal stories that we've heard from people benefiting from BFR across a variety of different populations, especially those patients who are recovering from ACL reconstruction. Here is a little bit about myself. As I mentioned, everything I do is to help me accomplish my mission of getting patients back to the activities that they love as quickly as possible and to experience the joy of pain-free movement. Blood flow restriction is the most compelling therapy that I know to help me help my patients. And I'd like to introduce you to one of my colleagues, Buff, the BFR Pro. He'll help me a little bit today throughout the presentation by highlighting some of the important points. And he's going to ask, are you ready to chase the pump? So before we begin, it's important to have a basic understanding of what BFR actually is. So this is a brief video that we've created for your enjoyment and also understanding.
Blood flow restriction is a fast-growing therapy to accelerate performance and recovery. A cuff, calibrated by technology, safely applying pressure to the normal leg, reduces the ability of blood to pump back to the heart from that limb. It increases muscle oxygen demand, causing the muscles to work harder to produce contraction. BFR stresses the muscle at rates where it normally would not be stimulated. So most people can increase muscle strength using much less weights than usual or no weights at all. When administered by certified skilled providers, BFR can help post-surgical patients, return strength to the elderly, assist athletes, potentially reduce the need for knee surgery, and much more. BFR is easy to use, hardly misused, better for results, and above all, safe. Accelerate your patient's performance and recovery with the proven therapy of blood flow restriction.
Yeah, that's my favorite part of the video. So as the video highlights, BFR is easy to use, hard to misuse, and when administered by a skilled provider is safe. And most importantly, when compared to conventional therapies, BFR is better for results. So now that we've discussed an overview of BFR, let's discuss how blood flow restriction can benefit those patients that undergo ACL reconstruction and their rehab. The first thing I want to really emphasize, and I can't emphasize it enough, is that that BFR complements your traditional plans of care. It does not replace anything. Let me say that again. BFR complements what we're currently doing with our patients that undergo ACL rehab, reconstruction rehab, and it does not replace it. So there are three common problems in ACL reconstruction recovery and rehab where BFR can help to help accelerate that rehab. And I'll touch briefly upon these in this presentation. These problems, rapid muscle atrophy, loss of quadriceps muscle strength, and post-operative knee pain are large reasons why ACL reconstruction rehab is so challenging to recover from. BFR can help accelerate the recovery from ACL reconstruction surgery by helping resist muscle atrophy and by building muscle strength. There's one important caveat to consider before we begin. That is, there are no set post-surgical guidelines for introducing BFR training into the post-operative plan of care for that ACL reconstruction patient. It's all based on the preference of the surgeon. So you want to make sure that you communicate with your patient's surgeon before you decide to introduce something like blood flow restriction into their plan of care. It's really, really, really important. When I discuss and I meet with surgeons, one of the comments that they give is that they fear for unilateral decision-making by the physical therapist. And so when I go out and I talk to other physical therapists, because this is one of the most common questions that I get asked, I want to just re-emphasize the fact that it's important to keep an open line of communication with your patient's surgeon. However, what we do know is that research says that it's really safe to begin BFR as early as the 3rd day post-surgery. And all of the studies that have been performed have reported really no serious adverse events like blood clots, rhabdomyolysis, etc. So as I just mentioned, a question that I normally get asked is how do we know when a patient is ready to perform blood flow restriction? Well, this study gives us an easy guidelines on when a patient is appropriate to start BFR given surgeon clearance. The inclusion criteria for this study, this is the Hughes 2019 study that we'll talk about briefly in the next couple of slides as well, was that the patient was a minimum of 2 weeks post-surgery, and they had to be able to demonstrate these five features. It had to be able to balance on the surgical leg for longer than 5 seconds. They needed to be able to demonstrate repeated straight leg raises without any appreciable quad lag. They needed to be able to bend the knee, not Game of Thrones, but bend the knee to 90 degrees. They needed to be able to have visible hamstring and glute contractions. And then last, which is the most nebulous of the inclusion criteria, was that they had to demonstrate no increase in additional knee swelling following activity. So again, that's pretty nebulous, but generally speaking, when I talked to Luke a couple of weeks ago, he just said that no additional increase in swelling above what you would normally anticipate that patient to have. I don't know if that helps or not. Anyways, the 2 stars in the first bullet point are highlighted because in the second slide following this one, I'm going to talk about a passive cell swelling protocol that can be used, generally speaking, within the first couple of weeks, almost immediately post-surgery to help reduce or attenuate post-surgical muscle loss in the quadriceps. So now I'd like to share with you some recommended BFR protocols and goals based on all of the published studies using BFR training in individuals post-ACL reconstruction. So I've arbitrarily created these 3 different stages of rehab with their corresponding goals. The goals of the first stage, so early stage 0 to 12, is to resist and attenuate the loss of quadriceps muscle mass. The middle, which is the 3 to 6 month mark, is to really improve upon quadriceps muscle strength. And then lastly, in the chronic phase, so you're talking 6+ months out, it's still to increase quadriceps muscle strength, but also with a focus on normalizing the limb symmetry index to prepare for return to sport. As I mentioned before, if this would be a protocol that you would use in the first couple of weeks. If your surgeon is comfortable performing BFR before the first 2 weeks, cell swelling can be a great place to start to help acclimate the patient to the unique stress of blood flow restriction exercise. Cell swelling is very low demand and by definition involves no active muscle contractions. You would perform cell swelling protocol by inflating the cuff to approximately 70 to 100% LOP for 5 minutes with the patient supine and deflate for 3 minutes and repeat that process 5 times. Now, LOP stands for limb occlusion pressure, and it's the minimum pressure needed to completely restrict both arterial flow and venous return to that limb. BFR exercise is standardized to the individual. So all the pressure that you're going to be applying to the individual during their rehab is relative to them, right? And that allows us to perform exercise in a safe manner because we're never going to be giving a patient an arbitrary pressure to perform exercise. So the research and convention in practice dictates that you can perform BFR exercise from 40% to 100% of the limb occlusion pressure as shown. All right, so getting back to cell swelling, these protocols have shown to be somewhat effective at attenuating muscle loss during the initial stages of ACL rehabilitation based on the research. As I just mentioned, cell swelling is a very low-level protocol that takes up a lot of time in the clinic. Not to mention that if you flip through the back of the slide before, you can see that it's performed 1 to 2 times per day, which is not feasible in the clinical setting for most individuals. So it's important to bridge away from this protocol as quickly as possible. If cell swelling is indicated by the presentation of your patient, you can optimize your time spent in the clinic by having the individual perform things like gait training or your manual therapy or your neuromuscular re-education during that 3-minute rest period. But most people can actually handle a little bit more intensity, and you can progress this intensity by pairing it up with things like neuromuscular electrical stimulation. So NMES, or neuromuscular electrical stimulation, can be performed at 75 degrees of knee flexion. And this will put a partial stretch on the quadriceps while also being in the protected range early in rehab, in that 90 to 45 degree range. So it's a very nice addition to the earlier stages of BFR rehab with your ACL client. The best solution, and the solution I fully believe in, is to get the patient as active as possible, as early as possible with BFR based on their presentation. And this will help accelerate their recovery in the rehab process. The goal for everyone undergoing a BFR training is to get to resistance training as quickly as possible. Some can do it on the first day that you see them, some can't. It's all about what the patient can tolerate and what you think the patient can tolerate. Low-intensity cardiovascular exercise can be used as a bridge from cell swelling to resistance training because it provides an intermediate stress that's higher than cell swelling but lower than resistance training. So it's normally very well tolerated by your patients. An easy-to-implement protocol would be walking or cycling at 30 to 50% of the individual's what we call resting or heart rate reserve, HRR, up to 20 minutes at anywhere from 60 to 80% of the LOP. Cardiovascular exercise can be used either before rehab or most likely after you've done your resistance training and other protocols. Once you determine that the patient has more tolerance for BFR, you can then progress to the more demanding exercises, aka resistance training. When starting resistance training with BFR compared to free flow exercise that we would normally be doing with a patient in the clinic, there is an increased potential to experience delayed onset muscle soreness, or abbreviated DOMS, due to the BFR stress. So when integrating BFR into the plan of care, it's important to make sure that the protocol is able to be successfully completed by the patient, which will reduce the chance for significant soreness. Exercise with BFR does exhibit a repeated bout effect, though. So if the patient does get sore from the initial application, they're likely to never get sore again. It's actually pretty cool. The protocol that we commonly utilize in practice is 30, 15, 15, 15, meaning 30 repetitions on the first set, followed by 3 sets of 15 repetitions on sets 2 through 4, each with 30 seconds of interset rest between them. I typically recommend starting with a very light weight or no weight at all, and having them tolerate that exercise to not reach failure, meaning getting through all 75 repetitions, and then progressing up to 20 to 30% of that estimated 1 rep max, right? It's really important because the lighter you go, the less effective BFR tends to be. So the sweet spot is about 20% of the estimated 1 rep max. So really trying to get your patients up there as quickly as possible is going to benefit their plan of care. So when incorporating BFR into the plan of care of a postoperative ACL client, the priorities are obviously the quadriceps, right? But that doesn't mean that you can't do BFR on other muscle groups, like the hamstrings, or the calves, or even the glutes. One study, that was Luke's study, that we're going to talk about next, performed a single leg press. That was it, a single leg press over 8 weeks, and showed considerable benefit compared to heavy lifting, which makes this exercise a great option for those that are just looking for a place to start with their patient. So I just wanted to take a couple of minutes to highlight one of the best studies that we have that currently exists on ACL rehabilitation, which I just alluded to in the previous slide. Hughes and colleagues took 28 individuals post-op ACL and randomized them into either low-load BFR, performing the 30, 15, 15, 15 repetition scheme at 30% of the estimated 1 rep max, at 80% of the limb occlusion pressure, or they randomized them into a heavy loading group that performed 3 sets of 10 repetitions at 70% of the estimated 1 rep max. Each group only performed the leg press over 8 weeks, twice a week. They took a ton of outcome measures that included strength, muscle size, perceived functional disability, as well as looked at knee joint pain both during and up to 24 hours following the completion of each exercise bout. His results really support the notion that BFR can accelerate rehabilitation and improve the quality of life in individuals post-ACL reconstruction. The results showed that BFR produced equal strength increases and similar changes in muscle thickness compared to the heavy loading group. But the BFR group improved virtually more in every other category measured, including all self-reported measures of function and perceived disability, total knee joint range of motion, and change in knee joint swelling. Not to mention pain relief, which is something that we will talk more about shortly. Just to briefly comment on the graphs, which is plotting peak torque values of knee extension and knee flexion on the right at 60, 150 degrees, and 300 degrees per second, you can see that for the quadriceps, BFR and heavy loading were equivocal at slower isokinetic speeds, but the higher speeds, which require more type 2 fiber conditioning and recruitment, the BFR group was able to maintain their strength throughout the intervention, in which the heavy load group lost a significant decrease from pre to post. A similar trend was shown on all 3 with the hamstrings as well. So together, this supports the notion that a simple closed chain exercise performed with BFR could reduce the degree of high velocity strength loss compared to heavy load training while providing superior improvements in other domains. BFR can accelerate recovery. Last, Luke is actually tracking these individuals and will perform a long-term follow-up study to look at their outcomes. So stay tuned for that. It's important to understand that BFR is a tool that serves as a bridge toward heavier loading. This concept was nicely illustrated also by Luke in a systematic review that analyzed the differences between strength differences between low load and low load BFR compared to low load BFR and heavy lifting in clinical orthopedic patients. So this is just a general orthopedic patient population. This systematic review concluded that while the majority of people will benefit from including BFR in their plan of care when you compare it to low load exercise alone, many more people will get stronger just lifting heavier. So it's important to keep that mindset and get the patient in a position to lift heavier weights as soon as possible, because that's going to give the patient larger benefits long term. A very cool and promising application for BFR is promoting significant pain relief. There have been many observations made regarding this in the research, both on ACL reconstruction as well as other groups of patients. Here's an adaptive protocol from Korakakis' research that can be used in clinical ACL rehabilitation. His published protocol had individuals with knee pain perform leg extensions with and without BFR in a failure 15-15-15 repetition scheme with up to 5 kilograms prior to functional loading tasks like a step down or a shallow or deep single leg squat. The BFR group experienced significant differences in reported pain compared to the low load free flow group. So in clinical practice, a simple way to modify this protocol early in the rehabilitation process would be to perform leg extensions in the protected range, or just use the leg press as that also has been shown to provide significant pain relief during and up to 24 hours following exercise. That was Luke's study that we just talked about. Now that we've entered what I've arbitrarily called the middle phase of ACL rehab, the goal is to continually challenge the cardiovascular and musculoskeletal systems to prepare them for later stages of rehab. High-intensity interval work, when appropriate, can significantly benefit cardiovascular capacity or VO2 max. Here's one protocol that can be used twice a week for up to 7 weeks to significantly increase VO2 max. You can have your patient perform 4 near max to failure or near max to maximal sprints on a bicycle for 30 seconds, followed by 4 minutes of inter-repetition rest. During the first 2 minutes of inter-repetition rest, you have blood flow restriction on bilaterally on both legs, occluded at about 60% of the LOP. You would then add 1 repetition every single week till they get to about 7 or 8 repetitions for their interval work, and that has been shown to significantly increase cardiovascular capacity in very well-trained athletes, athletes that have a 50 to 55 or above VO2 max, and that happened in multiple studies. At around 3 months, resistance training should be dominated by moderate to heavy loads. BFR should be used as a periodic deload from these protocols to reduce joint stress, or be used as a supplement to drive maximum fatigue to the targeted muscles following a heavy lifting session, right? That would be my ideal way that I would pair that. Throughout this time, BFR should have been used with various open and closed chain exercises. You know, the majority of research has used leg press, terminal knee extensions, along with straight leg raised flexion, which if anybody has ever performed BFR and has done straight leg raised flexion, it is a very, very, very challenging exercise. During this period of time, I would have also suggested that people periodically include failure training to specifically to maximize the stress on the targeted muscle, especially if an individual is not progressing along as they should and their quadriceps are lagging. Right? A safe bet to perform these type of exercises would be full range leg extensions. Once you get past 6 months, the goals should be to continue to normalize the limb symmetry index and prepare for returning to sport. BFR can continue to be used as an adjunct to heavy lifting 2 to 3 times per week to maximize stress to the muscle. However, in patients who are struggling to normalize their strength and increase their quadriceps muscle mass, a high-frequency BFR protocol has been shown to accelerate the improvement in size and strength in individuals who are at least 2 years post-operative. This protocol was given as a home exercise program that was performed 5 times per week for 4 weeks at 50% of the limb occlusion pressure. Exercises performed were quarter squats and leg extensions, as well as 3 sets of 2-minute walking intervals. After 4 weeks, the limb symmetry index improved, and patients had increased their quadriceps values relative to themselves, but also relative to uninjured controls. That provides a nice avenue and something that I've had success with in my own clinical practice to get muscle mass and strength fast. It truly does accelerate that process. So to summarize, after 50 years, BFR is becoming mainstream due to the research being published supporting its use in practice. Its unique properties allow patients to build muscle mass and strength using light loads when heavier loads are contraindicated or unable to be performed for whatever reason. BFR can provide an excellent complement to what we are doing currently in ACL rehabilitation and help accelerate the recovery and rehab process. BFR can help improve cardiovascular capacity over normal types of exercise, and we have our patients do in clinic, and even supersede some of the benefits over normal training when combined with high-intensity work. BFR helps ACL patients return to the activities that they love as quick as possible. So I think BFR is better for results. So here is just the reference list. And thank you very much. Appreciate your time.